Good evening. Good evening to our faculty, examiners, and delegates all over the India. It's a pleasure for me to moderate this session on cardiogenic shock with examiners being my own teacher, Dr. Saurabh Taneja from Delhi, and one more, Dr. Didipya sir, eminent consultant from Chennai. So we have a mix from both North India and South India. So we will see how the perspectives change, or is it the same all over India? With the recent danger shock trial, which has been shown that mechanical circuit devices play an important role in cardiogenic shock. How it has changed our perspective in managing cardiogenic shock, we'll probably try to understand on a case-based scenario. Dr. Sai and Dr. Srivats, over to you both. Shall we go ahead, sirs?
Please. Thank you. Thanks, Dr. Manindra, for having us here. It is a pleasure always to be on the Yashoda's webinar. A lot of learnings and a lot of interaction. Very happy to do it with Dr. Saurabh Taneja. Thanks for the opportunity. Thanks to Kola, Venkramana Kola, and Kaladar as well. Thanks, Manindra.
Saurabh, sir.
Yeah, thank you all for having me here. All the best to the students, and just relax and present the case as you will be in the exams. And thank you, Manindra, and thank you, Kola sir, for having me here.
Thank you, sir. Good evening, everyone, sir. Yeah, myself,
Good
Dr. Sai.
Good evening.
Dr. Srivas, sir.
Hello, sir.
So today we are going to present a case about cardiogenic shock.
So just present the case as you don't know the diagnosis.
Yeah. Okay, sir. Yes, sir.
That will be best.
So chief complaints of the patient, a 66 years male patient presented with shortness of breath, NIHA grade 2 since 2 to 3 days. Then he had worsening of shortness of breath since morning, progressed from NIHA grade 2 to grade 4. Initially went to local hospital, was intubated electively in view of increased workout breathing and hypotension. Started on dual vasopressor support, noradrenaline and vasopressin. So shifted to our hospital for further evaluation and management in a state of GCS E1 VT M1 in emergency department. He was conscious before intubation at outside hospital and receiving vitals to ER with heart rate of 133, systolic BP of 80 on vasopressor supports, respiratory rate of 22, saturations of 96% on control mode of mechanical ventilation, sir.
So, can I start, sir?
Yes, please.
So, why did you do a NYHA in the shortness of breath? And where was NYHA initially started? In which particular subset of cases do you do NYHA?
Sir, in
Okay, can you tell me the NYHA grade 1 to 4?
yes, sir.
Please.
So in grade 1, there is no restrictions of physical activity, no limitations of daily work, sir. In grade 2, there is limitations of, small limitations of physical activity.
In grade 3, there is a limitation in physical activity and only comfortable in resting, sir, in resting state. And grade 4 is complete. Even in the resting state, the symptom SOB will be there.
Srivats, can you be loud?
Yes, sir. In grade 3, the symptoms will be there in continuous symptoms will be there, sir. The patient will be comfortable only in the resting state. In the grade 4, the patient will be in restlessness and SOB even in the resting state, sir.
So this was basically started for heart failure. And so grade 1 to 4, as you said, 1 is no symptoms. 2 is that ordinary activities brings out the symptoms. 3 is just less than ordinary activity, and 4 is that symptoms are at rest.
Yes, sir.
Now that the patient has come to you,
Sir.
as you're receiving this patient with this, they're calling you from the ER saying we have received this patient, can you come and see or whatever. So what are the thoughts that are going through in your mind about the possibilities that this particular patient can have, the diagnostic possibilities?
Patient can be having any acute myocardial infarction with cardiogenic shock or sepsis with septic shock, any community acquired pneumonia, any ARDS and septic shock. Acute pulmonary thromboembolism also we have to rule out, sir.
So basically, you are saying that you're ruling out a whole gamut of pure cardiac or pure respiratory related or other system related.
Yes, sir.
Basically, you'll need more history,
Yes,
right?
sir. Yes, sir.
Basically, you'll need more history.
Yes, sir.
Okay. Any particular history that you'll ask over the phone to these patients? I mean, to your ER colleague?
So before presentation of shortness of breath, any chest pain,
Okay.
previous history of any underlying comorbidities, sir, diabetes, hypertension, any history of ACS symptomology in the past also.
Okay.
Any fever history or any acute abdomen symptoms, any travel history, so that we can narrow down to the diagnosis.
You will have to take a history for each and every differential that you suggested, all
Yes.
5. So tell one by one. I mean, for acute myocardial infarction, cardiogenic shock, what is the history that you want to take?
So for myocardial infarction, we see typical features. I mean, angina type of pain, sir, chest pain.
You said then.
Then any orthopnea, paroxysmal nocturnal dyspnea in case of any heart failure this conditions, left ventricular failure.
What sir was asking, try and rule it out one by one and think about the history for each of the differentials. Is
Yes.
it correct, sir? UDV, sir?
Yes.
Yeah. So try and rule it so okay, chest pain, orthopnea, PND, and then for the second differential, you said community acquired pneumonia, septic shock.
Yes, sir. Any fever, cough with expectoration, travel history, contact with source, then for acute PTE, any recent history of prolonged immobilization.
Yes.
Recent surgeries or any
Surgery, any trauma,
major abdominal surgeries, trauma.
Any previous history of DVT in the past, cough
Yes,
swelling?
Yes, sir.
Okay.
take a history of COVID as well.
Yes, sir.
COVID. Then any other differential that you were suggesting?
Other than MI, what other heart disease can you have that can cause breathlessness?
The valvular heart diseases can cause, sir.
Okay.
arrhythmias can cause.
Okay. Fine. You said he had a GCs of 3 in the ER and he was conscious before intubation in outside hospital. How
Sir.
is it important?
So while transport, they might have given any sedatives and paralytics. Or any the cerebral hypoperfusion also can happen, severe shock. Sky D and Sky D.
Okay. So you want to know what is the GCs of the patient because we want to know whether you have only one problem at hand or many other problems in hand, right? So that may also help you plan certain investigations before you actually shift this patient. Okay. I think we spent a lot of time in this first slide. Should we move on, Dr. Saurabh? I don't know.
Please.
Yes, please go on. Okay, so these are your differential diagnoses, is it? Cardiogenic shock with probable acute MI, community acquired pneumonia, acute PTE, septic shock, valvular heart disease. And you did rule out most of these in your history. Okay.
Next.
So initial investigations we advised was for CVP, RFT, liver function test, chest X-ray, ABG, PT with INR, troponin I, NT-proBNP, ECG, 2D echo, and blood culture, sir.
So you should try, and whenever you say you order these investigations, you have to tell why you ordered these investigations, keeping what differential in mind, what were your thoughts behind ordering an investigation, whether you wanted to make a diagnosis, whether you want to take the severity, you wrote in differential. So you have to tell each and everything about the investigations.
Yes, sir. In CVP, if there is any leukocytosis or thrombocytopenia, we can have a sepsis or infection in mind, sir. Then elevated renal function tests can give a clue about any acute kidney injury or renal hypoperfusion, sir. Then deranged LFTs can give you about any clue about congestive hepatopathy, sir. Chest X-ray may reveal any cardiomegaly or pulmonary edema features with any pleural effusions, consolidations, cavities, and those kind of picture we can roll out in chest
Please
X-ray.
continue. You're doing well.
So, in ABG, there will be we need to see any acidosis components, sir, along with elevated lactates, alkylate abnormalities we can see, and saturation levels in ABG we have to see. Then PT with INR coagulopathies will be there. So there will be derangement if congestive hepatopathy or usage of any anticoagulations, VKA anticoagulation. Then tropi will be elevated in myocardial injuries due to myocardial infarction, myocarditis, or even in AK and CKD also it will increase. Then NT-proBNP will be elevated in heart failure, sir. Then ECG reveals any ACS syndromes, arrhythmias. Then
Continue. We'll look.
today to give a clue about functioning of the heart, registrative lesions, regional wall motion abnormalities, along with ejection fraction, LV or RV failures. We can rule out, with TAPC and RV dysfunction, we can rule out PTA also. In severe PT,
Let's see the complications of MI in 2D echo.
Sir?
You can see if they have a patient of MI, you can even have the complications of MI in 2D echo.
Yes, sir. Like ventricular rupture can happen.
Many things can happen.
Dual rupture. Mitral regurgitation we can see, sir.
So next slide will continue. Sir, can you continue?
Yeah, please.
Yeah.
Just the ECG, just a minute.
Sir.
Okay. So that's the ECG of the patient. Can you just read this ECG for us?
Sir. So, patient is having T wave, sir, in 2, 3, and AVF, ST elevation in 2, and ST elevation also in V2, V3 is there, sir, along with Q waves in V5, V6, sir. Most probably evolved inferior wall MI, sir.
Then why in V5, V6 also?
Sir. V6. L6 stator also might be involved, sir. If it is involving more than one vessel.
Okay. Lateral, I'm not very sure. Inferior, definitely. And
Sir.
V2, V3, we do have some changes. So you want to call this as acute ST elevation MI involving the inferior leads and some ischemia in the anterior portion as well.
Yes, sir.
Okay. ABG?
ABG is having elevated MCAP is 137, 115 plus 40, 129. So normal anion gap, metabolic acidosis with respiratory alkalosis, sir. Elevated lactate, so lactic acid is also present with uncontrolled sugars.
Okay. Now,
Hyperkalemia.
normal anion gap, is it?
115 plus 11, 26.
Sodium and potassium is 143. Chloride is 115. Bicarb is around 11. So 126. So 143 minus 126.
17.
17.
So elevated, no?
Yes,
Okay.
sir. I
Okay.
know.
Are these two the only investigations that are positive? Everything else? Any other investigation that you want to tell us? Okay. Based on this, what do you think is the diagnosis of this patient?
Acute coronary syndrome, sir, with acute myocardial infarction with evolved MI involving RCA, LAD territory, along with shocks, elevated lactates and everything. Along.
Okay. What other investigations would you want to get done at this point of time?
Bedside ultrasound, 2D echo would be, it's better to do so at this point of time.
Good.
Okay.
You don't want cardiac biomarker?
And troponin anti-proBNP can be answered. I mean, troponin I can be answered.
So what do you think about the classification of shock, cardiogenic shock? What is this patient, and do you know about any classification of cardiogenic shock?
So SEI classification is there, sir.
Can you elaborate, please?
Lactates, then
There are 5 stages, sir. Initially, there is 5 stages, A, B, C, D, E, sir.
Okay.
His patient is a normal, sir, and B, there is a hypotension, but there is no hypoperfusion. C is there is a classic hypotension plus there is a hypoperfusion is there, and D is a
Okay. You're right. Can I just help you to put it plainly? Just take that. You have this A, B, C, D, E, no? It goes by an acronym. A means at risk. B means beginning.
Yes,
C means
Classic.
circulatory shock beginning. Okay.
yes, sir.
D is deteriorating and E is an extremist. So based on that, can you now tell us what it is? A is at risk. What do you mean by at risk?
There, when there is a propensity for cardiogenic shock, like large acute myocardial infarction or any degenerative conditions, in those kind of cases, patient may progress into cardiogenic shock, sir.
So you're anticipating that this particular patient is likely to have cardiogenic shock when he at this point of time is not having shock. You think that in the next few hours,
he might progress
a day, or he may develop cardiogenic shock. Fine. Okay. Then what is B?
B is hypotension present, sir, with hypoperfusion.
Will hypertension present or okay, hypertension. Okay, system. Okay, fine.
Yes, sir. Hypotension present with features of hypoperfusion.
With no features of hypoperfusion.
No features of hypoperfusion, sir. And B. So basically, there's no.
At risk is the patient may develop hypotension or hypoperfusion. So it goes from at risk to beginning. When it begins, only hypotension is there, but no hypoperfusion is there.
Yes, sir.
Then moves to the classic when both of them are there.
Yes,
So
sir.
how do you check for hypoperfusion?
Any end organ.
You did an ABG, something in ABG. Can it
Lactates are
help
more
you?
than 2, sir. In ABG, it's showing the hypoperfusion. And if at all urine output is less than 30 ml per kg, that is also renal hypoperfusion. And CRT more than 2 seconds, that is also indicates the hypoperfusion, sir.
Then move on to D. What was the deterioration?
Deterioration. The requirements of vasopressor support and increasing the requirement and persistent increasing of lactates. These are comes under the D, sir.
And then E?
These refractory shocks, even with vasopressor support or supportive temporary mechanical circulatory devices also, at risk of having cardiac arrest or pulseless electrical activity, then arrhythmias.
So very nice. You elaborated all the classes. Just
Sir.
to bring it again into perspective, A is at risk when patient is essentially normal,
Yes, sir.
but you're anticipating that they will develop hyperperfusion. B is where B is where there is a beginning pre-shock stage where you may just have a drop in blood pressure, or the blood pressure is normal. It is normal because of compensating mechanisms that have happened in this patient. So you will have extreme tachycardia. In
Yes.
both A and B, the lactates will be normal.
No,
Yes, sir.
yes, sir.
Because there is no hyperperfusion. You're
Yes.
right. You could look for other organ hyperperfusion features like urine output, like mentation. But as you can clearly see in this particular patient, he's already intubated in an outside hospital. GCS is 3. So your organ hyperperfusion for the brain doesn't work. Your urine output as it comes to you doesn't work. It needs some time for you to really look at it, right? And we may have a basic underlying cardiac disease. So if you're going to ask for one marker, of course, you don't look at one marker, you look at a lot of other markers. But one marker that will help you stratify if you made your diagnosis is lactate. If it's an elevated lactate, it is clearly C, D, or E. If it is a normal lactate, it can be A and B. But having said that, this patient can have elevated lactate from other causes also. No? So that being said, in a patient with cardiogenic shock, an elevated lactate suggests it should be C, D, and E. Now, why is this classification that you're saying? A, B, C, D, why is it important?
The management changes with each class, sir. That
Okay.
if at all the classic, if at all stay C, early revascularization might help. And when the mechanical circulatory supports we need to be, so
Okay.
that goes to the patient or management will be depends upon the what stages of the which stage of the patient is in.
Okay, so it helps you to decide different stages of giving
Yes,
mechanical
classification and
support.
therapy, sir.
Yes, sir.
Okay, classification. I'm very happy that you've looked at the newer SCAI classification of cardiogenic shock. But even before that, is there any other phenotypic classification of placing this patient in shock? In your examination, I saw everything. You've all. Is there anything more in terms of examination or anything that is going to come up? Next slide. Anything? Can you go to the? Okay, so ECG revealed Q waves in 2, 3 AVF, V5, V6. Okay, and sinus tachycardia, hugma, lactic acidosis, elevated creatinine. Okay, you've talked about high iron of metabolic acidosis. What are the causes of high iron of metabolic acidosis?
So diabetic ketoacidosis, sir.
Okay.
Then any toxins, sir.
Okay.
Alcohol injections, sir, like methyl alcohol.
Okay. Okay. Methanol intoxication, etc. Fine. Then lactic acidosis, you said.
Yes, sir.
You talked about elevated creatinine. Uremia can also.
Yes, sir.
So all of these are causes of high anionic metabolic. Okay. Examination, CVS S1, S2 heard, no murmurs, respiratory system, diffuse, bilateral diffuse Krebs, abdomen is soft. Okay. Anything else in the examination that will help you to classify the shock into simpler phenotypes?
If at all the patient is have cold extremities.
Okay.
And bilateral diffuse Krebs, and so wet lung plus cold extremities will say the
So what are the 4 types based on this classification phenotypes?
Patient, there are 4 types: dry,
wet, warm, cold, sir.
Yes.
So what are the 4 types?
Warm and dry is normal patient, sir.
Okay.
warm and wet patient. Uh,
So
So it can be warm, wet, warm, dry,
warm, dry.
cold, wet, and cold and dry, right?
yes,
So
sir.
four phenotypes are present in this particular patient. Okay. So based on your examination, I know you have not given the peripheries. In which of these four phenotypes did this patient fit into?
Um, cold plus wet, sir. The perfusion is low and
He was cold to touch and he was also wet.
wet.
Okay,
Yes.
fine. So in a patient who has got, just to sidetrack, in a patient who's got warm and dry cardiogenic type of shock, what do you think will be your management? He's warm and dry.
Warm and dry. It can be mixed shock, sir.
Sorry? No,
Mi-
I'm saying it's a pure cardiogenic shock. He's warm and dry.
So pure cardiogenic shock with warm and dry.
You want to start vasopressors, fluids? What do you want to do?
As perfusion is adequate, so as of now there is no need to start the vasopressor, sir. And dry is also there's no as of now there is no pulmonary edema component is there.
Patient is in shock.
He's dry, no? So what happens to a heart that is dilated? It may have to operate on a different portion of the Frank-Starling curve, no? It has to be probably distended to contract.
Yes.
So maybe, does he need some optimal fluid loading? Maybe this patient was on too much of diuretics. Maybe before diuretics have to be withheld, or you may have to be given some fluids, some optimal fluid resuscitation. Yes. So
Yes.
that's one. That's probably the easiest to deal with if you pick it up. We don't pick it up. That's probably the easiest to deal with, but maybe very difficult to pick up. Warm, dry shock. Okay, warm, wet. How would you treat them? This I'm sure you will be able to answer.
Diuretics will help, sir.
See, whether warm or cold, patient is in shock, like Saurabh sir told. So, whether it is cold or dry, whether it is wet or dry will decide what you want to do.
If it's
You can think
we
about
have to go vasopressor, sir. We should not give fluids.
if he's wet, you can't give him more fluids.
Yes, sir.
Yes, sir.
And you will be very cautious while giving fluids. So you might start on vasopressors.
Yes, sir.
In the longer run, you might diurese him, but not when he is in the acute stage of shock. Okay. So you have to be very careful. These are all classifications of shock. So phenotypic classification of shock are there. So remember, the shock is always there.
Yes,
So when
sir.
you answer, keep that shock in mind. Fine.
Yes, sir.
And coming to the first slide, why did you start noradrenaline? Okay, don't go back to the slide, but your first vasopressor was noradrenaline.
Yes, sir.
Wanted to discuss any basis for starting noradrenaline and not any other vasopressor?
SOAP 2 trial, sir.
What did the SOAP 2 trial compare?
Dobutamine versus norepinephrine, sir. Basically, the no mortality benefit is there, but
Dobutamine or any other thing?
Sir?
It was dobutamine?
Dopamine, sir.
dopamine.
Noradrenaline with dopamine, sir.
Dopamine, sir. Basically, dopamine has more arrhythmias risks, sir, but basically they don't have significant mortality benefit for each of us. So each drug. So that we will start norepinephrine, sir.
His phone தெரியாதா அப்ப 36 plus 4
Hello.
Sir.
And
Okay, so basically talking about the four different types of shock, warm and wet, you'll probably give him some, warm and dry, you'll probably give him some fluids and withhold diuretics. Warm and wet, you'll try to decongest this particular patient. Cold and dry, you'll definitely start them on
Vasopressor.
something to increase the contractility and may or may not give fluids because they are dry. First, you'll do that. And warm and wet, definitely you'll have to start them on vasopressor support and also have to decongest them. This is very, very simplistically saying. I'm just giving you the framework in which, but I think we can't go into broader depths at this point of time than this. Okay. So you've also done the 2D echo. And what does the 2D echo say?
You can read findings. It's on this slide only.
Global LV left ventricular hypokinesia is with regional wall motion abnormality in interventricular septum,
Okay.
apex, inferior
Okay.
wall,
Okay.
along with moderate mitral regurgitation with severe left ventricular dysfunction, sir, with ejection fraction of 30%, sir.
Okay. And you also done your POCUS, and that shows distended IVC 1.57 centimeters with no variation with respiration and a B profile on lung ultrasound. So what is the complete diagnosis at this point of time?
Might be acute myocardial infarction, sir, with left ventricular failure, with pulmonary edema and cardiogenic shock, sir.
Which stage of cardiogenic shock?
So, requiring vasopressor with
Classic
C, sir.
C, sir.
Okay. C.
Yes, sir.
Okay. Okay. Dr. Saurabh, you want to ask something?
Yeah, we were discussing about vasopressor, sir.
Ah.
They chose,
Yes, you're talking about vasopressors and you were asking about the SOAP trial.
we discussed about the SOAP trial, so I was asking why not epinephrine? Anything against epinephrine, vis-a-vis not epinephrine?
Yes, sir. Optimac trial showed that NORAD is better than epinephrine because epinephrine has both increase in mortality along with metabolic acidosis also present, sir, with epinephrine drug.
So it was not increased mortality per se, it was increased refractory shock.
Refractory shock, yes, sir.
Fine. We were discussing because your connection was out, sir, so we were discussing something else.
Yes.
You can move ahead.
So statin and antiplatelet loading doses given, started on maintenance doses. Patient was initiated on empirical antibiotics. Uncontrolled sugars were present, started on insulin infusion. Then hyperkalemia present, sir. So correction was given for hyperkalemia. Then hypotension worsened. Then patient had cardiac arrest for which CPR was done as per ACLS protocol. ROSC achieved after 5 cycles. Return of spontaneous circulation. In the meantime, tropi came as 1.2, sir. Is elevated. Then a patient was shifted to ICU with in above clinical conditions.
So when you say ROS achieved, what do you do according to the ACLS protocol as in post cardiac arrest here when ROS is achieved? There's a specific algorithm for post cardiac arrest here. Do you have any clue about that? So you look after the vitals like ABC, then you, if the patients were intubated, you attach end-tidal carbon dioxide, monitor that. Look for whether the patient is responsive or not. Do a 12-lead ECG, whether he requires a cath lab. If it doesn't require a cath lab, he is non-responsive. You think about doing anything for the hypothermia. Are you aware about anything about the hypothermia?
Targeted temperature control we have to maintain, sir. Initially,
so if the patient is unresponsive, what is the temperature that you want to maintain? Or do you maintain any specific temperature? Any idea?
37 centigrade.
35.
Just avoid hyperthermia and maintain a normal temperature. That is good enough. Just don't avoid any hyperthermia. Okay. So not too much of hypothermia is required. hypothermia has got its own side effects. I mean, we can go on discussing that, but okay.
You said antiplating loading dose and statin loading dose. Can you just explain that alone to me, and for the benefit of someone who may not know it?
Ecosprin, 150 mg, sir. Then this thing, ticagrelor or clopidogrel can be given, sir.
How much? Do you want to just give 150 or maybe 300 aspirin? Do you want an entry-coated aspirin or you want to?
Yes, sir.
Yeah, of
300.
course, this patient you will anyway given a Ryle's shoe, which means you will crush it and
300
give it.
treatment
But if a
depends.
patient can swallow it, we don't want entry-coated aspirin, no? So loading dose, we definitely give.
Yes, sir.
Sure. Okay. How much of clopidogrel if you're giving clopidogrel?
150, sir. Then
150 or 300? Okay. Statins?
atorvastatin 80 mg, sir.
80 mg. Would you choose clopidogrel or would you want to choose any other in that class? What's the practice in your unit?
So now change to ticagrelor, sir.
Why is that so? Okay, how much will you give upfront? Ticagrelor.
180, sir.
Okay, please. So after this loading dose, what are you planning to do with this patient?
So now has he moved from class C to some other class?
Class E, sir, as the cardiac arrest and
Happened class E.
so class E, sir, you moved.
So what will you change as treatment? What do you think that you can do as a treatment or a management?
With temporary mechanical circulatory device, then early intervention, sir. Revascularization therapies also we have to see, sir.
Which mechanical assist or device are you familiar with? Are you
ECMO,
okay?
IABP,
IABP, tandem
heart.
So what will you use in this case? If you're asked for, what will you use?
Impella can be used, sir.
Okay. So what is the benefit of using Impella? What does Impella do actually?
So it will improve cardiac output, sir. Decrease the LV filling pressures along with improve the pulmonary congestion also, sir.
What is a normal cardiac index?
0.5 to 5, sir.
5, sir.
2.5. And when do you say it's a cardiogenic shock?
Less than 2.2, sir.
Less than 2
liters per minute.
minutes.
Liters per
Minutes, sir.
Meters. Meters square.
yeah, liters per minute per meter square. So that is how it's called a cardiac index.
Yes, sir.
Okay. So do you want to insert a pulmonary artery catheter in this patient? Any idea? Do you insert it regularly?
No, sir.
So and you have any idea in which subset of patients of cardiogenic shock do you want to insert a pulmonary artery catheter?
Right heart failure and
You're suspecting right heart failure. Then anything else?
pulmonary arterial hypertension, sir.
So especially in cardiogenic shock we are discussing. So
Refractory cardiogenic shocks.
refractory, okay. Then if you're unsure about the cause,
Yes, sir.
then also you do. So if you insert a pulmonary artery catheter, what are the outputs that you're looking for? Any idea? If you're not inserted, we'll avoid this question.
Pulmonary capillary wedge pressure can be seen. Then
Can you distinguish between a right ventricular and a left ventricular failure, right heart or left heart failure based on the readings of pulmonary artery catheter? Any idea?
so, pulmonary capillary wedge pressure will be increased in left heart failure, sir.
Okay.
It will be normal, sir, in right heart failure.
Okay.
Then right atrial pressures and CVPs will be increased in both.
More in the right heart, probably.
Right heart failure, yes, sir.
Fine.
Sir.
Can you move ahead, sir?
Just a question on this. So you've loaded this patient with antiplatelets and statins. You've treated with the antibiotics. You've tried to control the sugars, and obviously you had to treat the hyperkalemia and hypotension. What else will you do in this patient? Your diagnosis was something else, no? Acute myocardial infarction.
Yes, sir.
So,
Early revascularization therapies we have to.
so have you spoken to the cardiologist yet? So when we said that the plan is, I'm sure you have it in your mind. So let's not get carried away with things that we have to do. As soon as we give the loading dose, we should.
Sure.
Can you tell? I am the cardiologist. You're calling me and telling me. Tell me what you're going to tell.
So patient is having acute myocardial infarction with cardiogenic shock, had cardiac arrest, sir. Loading doses given, sir, with antiplatelets and statins. Immediate revascularization to be done. He is in cardiogenic shock. Along with ECG changes and drop, I will inform, sir.
Okay. But this patient has already had a CPR. I don't know what about his brain status. Maybe we shouldn't do this. We should call it off. That's what the cardiologist is saying. What do you want to tell him?
What kind of arrest was it? It was a witness or unwitnessed cardiac arrest?
Witness, sir.
Okay. So it was a witness cardiac arrest.
Yes,
What
sir.
was the GCS before it was witness? Low only. 2T.
Yes, sir. Low, sir. Yes, sir.
But when he came to you, he was 2T. But in an outside hospital, he presented with normal consciousness.
Yes, sir.
So will that all make a difference? So can you tell him this is a witness cardiac arrest and he had a prompt high quality CPR with Ross attained in 5 cycles. His GCS prior to admission to an outside hospital seemed to be okay. So I think it's unlikely that he has something major, and maybe it's still possible that he has a good functional outcome if you're able to fix the problem. Does it make sense?
Yes,
Yes,
sir.
sir.
Yes. Okay. So, but you've not given him heads up of which arterial territory is involved.
Yes, sir. Regarding RCA and LAD territories.
So, why do you say the RCA is the culprit vessel? Why do you say that?
Involvement of 2-3 AVF, sir.
Okay. 2-3 AVF.
Yes, sir.
In a patient with RCA territory infarct, inferior wall infarct, do you expect such degree of hypotension and cardiogenic shock?
No, sir. With left vessels, left involvement of any left main coronary or left circumflexor anterior descending, then we can expect, sir.
Okay. You said the RCA is a culprit vessel. Any other vessel that can be involved in this patient?
What were the leads that were involved in the ECG? That'll give you a clue.
Yes, anteroseptal, sir. LAD, left anterior descending can be involved, sir.
Okay. So you want him to take him for a angioplasty of, suppose there are 3 vessels involved. What do you want him to do?
CABG can be planned, sir.
Okay. Or emergency CABG can be planned or whatever. what do you think they will do?
So if any if there is major blockage in one vessel more than other vessels, first they will intervene. Percutaneous intervention will be done for that major vessel, sir.
So you're talking about a culprit vessel. So culprit vessel doesn't just tell you about the blockage also, but it can be chronic blockade also. So you also have to think in your mind what is the territory that is involved. So you'll have to go and do a culprit vessel plasty.
Yes, sir.
And suppose there are more than other vessels involved, he has to do a culprit vessel plasty, come back, leave this patient on some mechanical support device, and
Yes.
then reassess after 2 to 3 days. Or if necessary, take him up for CAB. That's what you said you will get it done. Okay, so you've spoken to the cardiologist. The cardiologist is willing to take him for a immediate revascularization procedure. Okay, can we, Dr. Saurabh, should we move on or?
Yeah, I was just saying that if you look at the symptom of the patient, initially he had a NYHA2 for 2 days and then he became NYHA2 to 4. So you can see that there are more initial, there was some initial blockade was there in 2-3 AVF and then you had Q waves and then this patient had V5, V6. So there are at least 2 vessels that are involved.
Yes, sir.
That is why the patient went bad. It might be a triple vessel eventually, but at least 2 vessels are involved. So you can think about doing a culprit vessel thing. Going by the history also, it gives you a clue.
Yes, sir.
You can move ahead. Yeah.
So we came with a provisional diagnosis of ACS with evolved MI, cardiogenic shock, sky classification of V, and cold wet phenotype, sir.
Okay.
So in past history, patient is known hypertensive with usage of calcium channel blockers and ACE inhibitors. Patient has previous history of chest pain and shortness of breath in past. Coronary angiogram was done. There was single vessel disease. Was advised for PTCA. They went on to another cardiologist who advised for only medical management, sir, with statins and antiplatelets.
Okay. That explains quite a lot of things.
Yes, sir.
You can move ahead. Next.
Personal history, he's a non-smoker, not on any NSAIDs and has no addictions. There is no significant family history. So day 1 of ICU stay and general examination, there was no pallor, no icterus, no cyanosis, bilateral pedal present, JVP was raised. Capillary refill time was more than 5 seconds with heart rate of vitals with heart rate of 112 beats per minute, BP of 160 and NORAD with 0.25 micrograms per kg per minute and vasopressin of 0.04 units per minute, saturations of 95% and control mode mechanical ventilation, sir, with the fractional inspiration of oxygen of 40, PEEP of 8, tidal volume of 380, respiratory rate of 24 with driving pressures of 14 and platelet pressures of 20. Then repeat ABG revealed ion gap metabolic acidosis with lactic acidosis. Urine output was around 5 to 10 ml per hour. Nephrologist opinion was sought, sir, in view of uric AKI with ion gap metabolic acidosis, even after diuretic challenge with furosemide. No response is seen, so CRRT was initiated, sir, for 24 hours.
2 questions. Firstly, what did you decide in this case? It was emergency CABG or a culprit vessel PTCA. What did you actually decide?
Dr. Sai, what was the treatment that this particular patient actually received? That's what Dr. Saurabh is asking you in terms of revascularization.
Sir, as of now, revascularization was not done, sir.
Okay. And do you think that giving a diuretic challenge or a furosemide challenge with noradrenaline, vasopressin, is it a, you should have done it or? This patient already had a creatinine of 4 initially, if I remember correctly.
Yes, sir. It will worsen, sir.
Do you expect this challenge to work in the first place?
No, sir.
What do you think is the cause of his renal failure?
Hypoperfusion is a main cause for renal failures.
Renal
The
hypo.
cardiogenic
It's
shock
cardiogenic shock. Yes, sir.
with the renal hypoperfusion, pre-renal. We have not fixed it, so
Yes.
I think it may not work. But nevertheless, I think probably in as it is in many units, the nephrologist will initiate only if they
Diuretic challenge.
do. Okay, probably you did that. I'm just asking your opinion. Okay, I'm just curious to ask you some things. You said you are ventilating this patient on. What are the problems you're anticipating while ventilating patients with cardiogenic shock? You're intubating these patients at the time of intubation or just after intubation when you're initiating them on mechanical ventilation. What are the problems that you anticipate, either immediately or subsequently? And how do you think we can circumvent them?
Immediately, patient may land up in severe hypotension, sir. As due to maybe due to drugs initially and PEEP, as it decreases the further decreases the preload, and so and it will also decreases the eventually decreases the cardiac output. So as if the patient is already on the low cardiac output and it further decrease the cardiac output, so the hypotension may worsen, sir. And it also decreases the preload of right ventricular, increases the right afterload of right ventricle, sir. So patient may land up in severe hypotension, sir, post intubation.
Okay. So you can anticipate that post intubation in these patients with severe cardiogenic shock, you can expect a worsening.
Yes.
In these patients, which may have to be managed with vasopressor support.
Vasopressor,
Okay.
yes.
Why was there actually? Why did this patient not go immediately to the cath lab? I mean, I'm not saying what you have done was not right. I'm not questioning the decision behind it. I'm just asking a viewpoint. Do you think he could have been directly shifted to the cath lab?
The cardiologist was not Didipia, sir.
No. I'm just asking them.
No.
Each of us have a different way of maybe.
The way you told how to explain to the cardiologist, if we could have explained in that way, probably he would have gone.
No. I think we'll move on. Just the next slide, please.
So discuss with family regarding temporary mechanical circulatory support system. Family was unable to decide on mechanical circulatory supports.
What did you offer? Which device did you offer?
Imperial, sir.
Did you calculate any parameters before offering the device? Any parameters like cardiac power output, if you are aware about?
Yes, sir.
So what is that?
Sir, if cardiac power output is less than 0.6 watts, it denotes a severe cardiogenic shock, sir.
What is the formula? Why it is called cardiac power output? What are the units?
Watts, sir.
Watts. What is the unit of power?
Power, yes, sir.
What is the formula?
Map into cardiac output by 451, sir.
Okay.
So you looked at the cardiac power output. You use the formula map into cardiac output by 451. And what did this come out to in this patient? What is the value of the cardiac output in this patient? Less than 0.6 or more than 0.6?
Less than 0.6.
Okay. So what does that indicate? If it's less than 0.6, what does it indicate?
So pumping capacity of heart is very low and he's in severe cardiogenic shock, sir.
Okay, that indicates that there is a failure of medical therapy and this particular patient definitely needs a mechanical cardiac support. So that's the first question. But Dr. Saurabh Taneja was also asking you,
Sir.
you made the decision that this particular patient needs a temporary mechanical support device or based on calculating the cardiac power output. You said you're going to calculate the cardiac power output as a map into cardiac output by 451 and find out whether it's less than 0.6 or more. Less than 0.6. So you're saying that there's a likelihood of failure of medical therapy. So you're instituting a mechanical device. So he's asking you,
Sir.
on what factors did you make the decision that you use Impella? I thought you said you use Impella on this patient, right?
Yes, sir.
Okay. It could be simple. You can say, I have only these devices that are available in my hospital, and that's the only thing that I can use. It could be that. Or if you have all the devices available in your hospital, how do you choose?
By choosing Impella.
One by one.
So in acute myocardial infarction with the cardiogenic shock, for bridge to recovery, we can use with the Impella.
Okay.
Do you have any other devices with you?
Yes, sir. VA ECMO is there.
Have you used the VA ECMO?
Sir?
Have you used a VA ECMO?
Yes, sir.
Why didn't you offer a VA ECMO in this patient?
Sir, there is no, mortality benefit VA ECMO with acute myocardial infarction, sir, with cardiogenic shock.
Is there a mortality benefit with Impella?
Yes, sir. With danger shock trial, it denotes the early initiation of Impella, improved outcomes.
And have you inserted IABP anytime? Any benefit of using IABP?
Only for selected cases only, sir. There is no benefit, sir, with the IABP. It may improve hemodynamics only, but overall benefit is less, sir.
Okay. So they mentioned about VA ECMO, Impella, and IABP in the interview. Yeah. So can you combine any of these? Have you ever heard about a term in which VA ECMO and Impella are combined? And any logic of
Impella, sir.
Why do you do that? Any idea?
Left ventricular venting outs.
So in which thing you want the left ventricular venting?
Sorry, sir.
Why do you need a left ventricular venting?
In VA ECMO, there will be increase in afterload, LV afterload.
Yes.
There will be, it can cause LV dysfunction, sir.
Okay.
That time, to troubleshoot that problem, we have to vent out.
Fine. Very right.
So.
We can move ahead. Yeah. Good.
On day 2, after 24 hours of continuous renal replacement therapy, acidosis improved. Patient clinical condition was better. Hemodynamics improved. Vasopressors reduced to only noradrenaline support. Neurologically improved, sir. He was flexing to pain. Abnormal flexion, E2, VT, M3. Cardiology review was taken. Started on therapeutic anticoagulation with heparin, sir.
Was there any sedation when you checked this DCS? Flexion to pain? Any sedation ongoing in this patient?
Initially, only during intubation only we give sedations. After that, we did not give, sir.
Next 36 hours, no sedation was given.
No, sir.
Fine. So any questions?
Nothing. Is there any dose adjustment that you have to give for heparin for renal failure?
No, sir.
Okay. For low molecular weight heparin?
We have to avoid, sir. Dose adjustment need to be done, sir. Initially, normally we have to.
So there is some dose adjustment that needs to be done for low molecular weight heparin. For
Yes, sir.
plain heparin, dose adjustment generally is not needed for renal failure.
Yes,
Okay. You're giving subcutaneously QID.
sir.
In a patient with cardiogenic shock, how effective do you think the absorption of a subcutaneous?
Will be low, sir.
So
With
why
So-
do you do
and
that?
hypoperfusion with less absorptions.
So would it be okay if we could give it IV also?
Yes,
this
sir.
patient?
Can be done, sir.
Just thought. Yeah, please. Next.
So on day 3, patient underwent coronary angiogram, sir, which revealed 80% stenosis in LAD, LCX, and RCA vessels. Post coronary angiogram, one session of sled was done, sir. With a complete occlusion of RTS.
80% stenosis, LAD, LCX, RCA, how much percent stenosis? Sorry, I
100,
can't.
sir. 100.
100%. Okay. So he just had an angiogram. There's no revascularization attempt at that point of time also.
Yes, sir.
Okay. I was going to ask which vessels did they target, but they didn't do anything. Okay.
Okay, which vessel do you think they should have targeted? You answered this already before.
RC,
Maybe 2 days ago they were gone. They should have targeted the RCA.
RCA.
Okay.
Yes, sir.
Okay then.
That's fine. Yeah. You can move ahead. Yeah.
So on day 4, cardiologist advised for revascularization, preferably CABG. Patient hemodynamics were improving gradually and was off vasopressor support. GCS improved to E4 VT M6. PF ratios improved. SBT trial given. Tolerating pressure support mode. Hainan gap metabolic acidosis improved. RFT improving. Adequate urine output present. CTVS consultation done. Advised to review after a week, sir.
Oh,
So on day 4 only, you were able to extubate or wean the patient,
Yes, sir.
and GCS improved. Great. You can move ahead. Next.
okay. Just a question. You extubated him and you extubated him to anything?
No, sir, we did not extubate him, sir. He was maintained on pressure support mode only.
Okay.
So we thought of whether he can be taken for surgery. It was deferred. By the time it was in the evening, so we did not extubate him, sir. Anticipating an extubation, weaning failure, extubation failure, sir, with underlying primary insult is not resolved, sir. Not treated completely.
Fine. What do you think about giving an SBT with the TPs in this patient?
In which patients do you want to give SBT with TPs?
Okay. I'm coming and I'm telling you, okay, it's okay for you to give SBT, but avoid TPs in this particular patient. If I'm telling you this,
Sir.
why do you think I'm asking you? Can you just tell us certain conditions in whom an SBT with the TP should be avoided? Definitely avoided. One is patient with cardiogenic shock, cardiac failure. Another is some other failure. neuromuscular weakness?
Yes, sir.
Okay, so you've given him SBT with, on a pressure support mode. How much of pressure support that you give him on an SBT trial?
Uh,
Sorry?
10 mm of HC, sir, over 5 to 6 of PEEP, sir.
Okay, 10-5. 10
Yes.
pressure support, PEEP 5. Okay.
For how much time?
So, initially, 2 hours, sir, initially. Then prolonged to 4 hours, he was tolerating.
Okay. And what do you monitor over this time? Any patient you give SBT, what do you monitor?
Desaturation, saturation levels, any
So work of breathing, volume generation.
Answer in clinical as well as vitals monitoring. Okay. You
Yes.
monitor clinically any increase in work of breathing, any increase in respiratory rate, tachypnea, tachycardia, diaphoresis, and then all the vitals that you measure.
Yes.
Fine.
Yes,
In
sir.
any you give SBT. And this is a precious patient who's having a cardiogenic shock, is just being weaned on day 4. Still the vessels are still there and they are not being revascularized.
Sir.
This patient requires intensive monitoring while giving a SBT.
Yes, sir.
Next. Yeah.
This is the investigation trends.
I was wanting to ask initially, why did you start with carbapenem in this patient? I didn't ask till now because it's a cardiogenic shock. But you said you started with carbapenems.
Sir.
Patient who came to your hospital from the other hospital on probably the same day. Any clue?
Initially,
Started with carbapenem. What were suspecting? What were your thoughts?
yes, sir. Suspecting sepsis with septic shock.
Okay.
Along with
So when did you rule the septic shock out? And did you de-escalate the antibiotics after ruling out septic shock?
yes, sir. We have sent for Procel values, sir. Turned out to be negative.
So what did you do?
De-escalation of antibiotics were done, sir.
When was it done?
Sir?
When, on which day was it done? I couldn't see in the history.
So it was done on day 3 only, sir.
What was the procalcitonin value?
It was around 2.5, sir, but we did not document it here.
So at 2.5 procalcitonin you de-escalated?
No, sir. Ideally should be less than 2, sir.
You are getting caught in your own webs.
Sir.
Okay, chalo. We'll continue with the cardiogenic shock only. Some other day for septic shock. Next slide. It's okay.
Patient was found to have left hemiparesis with upper limb and lower limb power of 1/5, sir. On day 6, MRI brain was done, which revealed massive right MC and acetylatory infarct. Neurologist opinion was sought for further course of management, sir.
So did you do a echocardiography in between the first day 1 echocardiography till day 6?
Serial echocardiography monitoring was done, sir.
So any changes were found in them?
No, sir.
No changes.
No, sir.
No clot formation, nothing.
Sir, we did not find any clot in transit or clot formation, sir.
Fine.
So this patient was still intubated.
Yes, sir.
Still kept intubated. Day 4 he passed the SBT,
Yes,
but
sir.
still you were not very satisfied with him and you kept him intubated.
Sir.
And it's an in-hospital, in ICU stroke. Okay.
Yes,
So how do you how do you actually recognize an in-hospital stroke, in ICU stroke? How easy it is? How difficult it is? I'm just trying to understand from you. Day 6, you said. Could it
Sir.
have been in day 5? Definitely not on day 4 because you said M6 moving all 4 limbs. So
Sir.
I'm just asking, could it have been in day 5, day 6? What are your thoughts about it? First, is it challenging to diagnose stroke
Yes, sir.
Yes, sir.
in these patients? Why do you think, what are the challenges? Is an intubated patient, so you are on sedation.
Yes, sir.
Okay. So you have an hourly monitoring of the GCS. Do you think it regularly gets done? They definitely check the pupil. Maybe not at night. They don't usually check for all patients. Do they actually look at the movement of the limbs in these patients
Yes, sir.
every hour?
Hourly monitoring will be no, sir. It will be difficult only.
I'm not sure it's difficult, but it has the ideal thing to be done.
Yes,
Probably doesn't get done in most of the ICUs. This is nurse driven. So
Yes.
I'm sure as a doctor, you see once in a shift, you see maybe middle of the shift, maybe during handing over, you will again hand over to your person, you will examine and hand over or whatever it is. It depends on different units. But in between, it's the nurse who actually has to look at it. So it has to be a very nurse driven protocol. So most of the time, the nurse will be the one to come and tell you this patient is not moving this side limb, and that's when you go and actually see it. The question that I'm asking you is, suppose this was an in-hospital stroke, which is what it is. What are the therapeutic options that are available for you in this patient? We'll not deviate because I think we are dealing with cardiogenic shock. And do you think you could do a in-hospital? Huh?
Thrombolysis and mechanical thrombectomy can be done.
Okay. So for that, you need to know the duration. And time window, knowing the time window is a problem. So if you can't know the time window, how do you actually plan that?
CT angiography or MRI studies.
Why?
Any diffusion mismatch is there or not, we will see, sir.
Okay. So this is typically like your wake up strokes, right?
Sir,
Except that he woke up in hospital, not at home.
Yes,
So
sir.
the same principle that holds here as well. Okay. So you've taken a neurological opinion, and what is the further course of management?
So no thrombolysis or mechanical thrombectomy was done, sir. Managing conservatively only because it is a large infarct, sir.
Okay.
There is risk of bleeding, sir, with thrombolysis.
Okay.
So obviously this patient, even if he had anything that is doable, you can't, because it's a large MCA territory. In fact, that's fine. Okay. Next slide.
So in view of prolonged weaning, tracheostomy was done, sir, for the patient.
Patient was on heparin, or this time when you did a tracheostomy?
So,
Or it was stopped, and how do you manage that when you want to do invasive procedure, a patient on heparin?
so APTT levels monitoring, so
Okay.
then along with
Do you stop or withhold heparin?
sir, yes, sir, we have to withhold, sir.
For how much time?
4 to 6 hours, sir.
Okay. So did you do that in this patient? Must have done it.
Yes, sir. Yes, sir.
Must have done it. So you'll be familiar with the guidelines for that, because patient on heparin, you want to do a tracheostomy, should be familiar with. You have to monitor the APTT, withhold it for 1 or 2 half-lives, and then you can do it.
Yes, sir.
And CTV has suggested no active intervention for 6 weeks. Why?
So they thought then mechanical complications. They thought MR was there, sir, for the patient. In MR patient, early intervention, mechanical complication patients, early intervention is deferred, sir.
Was it because of the stroke or because of the MR?
Because of MRs.
Okay. I thought if it was a new onset stroke, you don't want to do a CT-based intervention.
It's also one of the reasons, sir. And already there is high risk of bleeding in the intraparenchymally with heparinization during the procedure. I mean, post-procedure.
Usually they stop intervention for 4 to 6 weeks if you have a major stroke, and then you do a CT-based or any major surgery or intervention. Anything else, sir?
Nothing, nothing there. So CT-based deferred surgery for 4 to 6. So this is a stroke. So you would say it is a cardioembolic stroke, right?
Yes, sir.
But you are unable to demonstrate an embolus
Yes,
on
sir.
an echo.
Yes, sir.
Okay. Is there a role of any anticoagulation on this in these patients?
Yes, sir. With severe cardiogenic shock and cardioembolic stroke, we have to inject anticoagulations to prevent recurrence.
So did you
Is
start?
there a high risk of bleeding in these patients who are on, if they are on anticoagulation, will you still continue dual antiplatelets or what will you do? Okay, I think then I think we're sidetracking from cardiogenic shock to management of a neurogenic patient. We'll come back to this. So you're not planning any active intervention in this patient because you're anticipating that he will need valve replacement also, and that would need anticoagulation for a long duration of time, heparinization, and it can cause bleeding. That's the reason why the cardiothoracic surgeon deferred. That's what you're saying, right?
Yes, sir.
Okay. Doctors, so we can go to the next one.
Yeah.
So diagnosis of coronary artery disease with acute coronary syndrome, and STEMI, cardiogenic shock, which is improving, type 1 respiratory failure with moderate ARDS with pulmonary edema, and mechanical ventilation, aspiration pneumonitis, oliguric AKA and CKD, congestive hepatopathy, heart failure with reduced ejection fraction, status post CPR status, coronary angiogram which revealed triple vessel disease, acute CVA with right MC and ACI tertiary infarct, most probably cardioembolic, with high gap metabolic acidosis, with lactic acidosis and uncontrolled sugars.
I think they managed it fairly well. I am going to ask some more questions, but they are again not on cardiogenic shock.
So,
I mean, day 7, 6, you are still taking uncontrolled sugars. Why were they still uncontrolled? Dr. Shiva?
So
How do you control the sugars in these patients? And why are the sugars deranged in this patient? You said the HbA1c was 6.7 or 6.8. I think that was the value. So why are the sugars deranged in this patient? Did you give any steroids at any time? And how do you manage sugars in your unit?
steroids not given, sir.
So do you give insulin infusion?
Yes, sir. Human insulin infusion will give, sir.
So you should be clear with everything that you write on the slide or you present in the case. The questions can come from any time or anywhere, any day of the treatment, and not focus on a certain thing.
Yes, sir.
And basically, sometimes you can just avoid certain things. You've written CRS1, which means you're talking about cardiorenal syndrome type 1, right?
Yes, sir.
If I were to ask you how many types of cardiorenal syndrome are there, you will be able to answer them. Can you tell me 1, 2, 3, 4, 5? What is 1?
Sir, acute cardiac condition leading to acute kidney injury.
Okay. 2.
Chronic cardiac injury leading to chronic
Superb.
kidney.
3.
3 is acute kidney injury leading to acute cardiac disease, sir.
Okay. 4.
4 is chronic renal disease leading to
Super.
chronic
And 5, any systemic problem causing that. That's perfectly fine.
Then you can
So
write.
if you very good. If you are very sure of it,
Sir.
commit. If
Sir.
you're not very sure of it, omit it, because these are the least significant things that you'll have to tell in an exam. But
Yes.
somehow you say this and the examiner latches on to it, and then you get sidetracked. So I think you manage this particular case very well. And the
Sir.
point that we probably just want to highlight at this point of time is this
Sir.
particular patient came to you with shock, and
Yes,
you
sir.
made a diagnosis of cardiogenic shock. You made a diagnosis of cardiogenic shock based on the history,
Yes, sir.
right?
Yes, sir.
And you did a ECG. ECG showed Q waves in lead 2, 3 AVF, and maybe you had some changes in V2, V3 as well. That's what you were saying. You
Sir.
did an echo, and the echo showed a regional wall motion change with a drop in ejection fraction and MR as well. And you did a drop that was negative. So you had at least 3 upon the 4. The only other 4th thing was symptoms, chest pain, and he couldn't have complained to you because he came intubated elsewhere. So you made the diagnosis of an acute MI with cardiogenic shock.
Sir.
And you said that you made a diagnosis of cardiogenic shock, and this patient was on a cold wet phenotype.
Yes,
because
sir.
he was cold periphery and he had Krebs all over. So he had cold wet phenotype. And he also talked about the sky classification. You did say that he was in E. I think that's debatable. Maybe he was C and D. I'm not sure whether he was in E already, but I think I'll leave that to you. So you knew the classification as A, B, C, D, and E. A at risk, B is beginning, C is cardiogenic shock occurring, D is deteriorating, and E is in extremis. If the patient has got an elevated lactate, then it is C, D, or E. Otherwise, it's A and B. In A, everything is fine. In B, maybe just drop in blood pressure or compensated. C, D, and E, we looked at it, right? You were
Yes.
able to talk about that as well. You did say that if this patient comes to you, your job is to give him the loading dose of antiplatelets. You did tell us about aspirin and clopidogrel versus ticagrelol. And then you said you'll also give a loading dose of statin, give heparin, and call the cardiologist for doing a culprit vessel angioplasty. And you said, how do you identify a culprit vessel even on an ECG? And obviously, it's best done on an angiogram. That's what you said. And you said, while doing this, you will support the inotropes, you will support the shock with vasopressors. You said you will give noradrenaline based on the SOAPS trial. And you also said that depending on whatever it is, either prior to procedure or intra-procedure or post-procedure, you will decide on a temporary mechanical cardiac support based on the cardiac output calculation. You also told us about the cardiac output, power output as cardiac output times MAP by 441, whether it's less than 0.6 or more than 0.6. Less than 0.6, you think that there is a failure of mechanical, failure of any of your medical therapy. So you will put them on mechanical device. And you said, how will you choose the mechanical devices? And you did tell us that what are the mechanical complications that a patient with MI can have? Can you just tell us that again?
Yes, sir. Free wall rupture, sir.
Okay.
Ventricular rupture.
Okay.
Papillary muscle rupture with mitral devastation, sir.
So free wall rupture, VST, and acute MR.
Yes,
and
sir.
you did tell us about management of all of this. And you also told us that these patients can have other complications like a cardioembolic stroke, and what is the challenge in recognizing and managing these patients as well. We
Yes.
also discussed about the challenges of managing these patients ventilator wise, both in initiation and during weaning. Weaning, we decided that don't err on giving a TP's trial on these patients. You will have to give them only pressure support and wean. Okay. I think we discussed a lot of other things with very well managed case. I think I just summarize what we discussed so far. Dr. Saurabh, any questions that you want to ask them, and then get Manindra also?
They did pretty well, sir, actually.
I think
They did pretty well. I mean, some bit of improvement in some things are required, but they're familiar with the questions now, and you summarize the case very well.
There are few questions from the audience.
Yeah, we should look at that.
Aspirin chewable tablets, how are they different from enteric coated? And what did you use? Sai Kishan or Shrivats?
Enteric coated tablets, they use with crushing them, we have to use. Patient is unable to chew.
Fine.
Okay.
Uh,
So when you crush them, entry coated anyway goes away, no?
yes,
But
sir.
if you're going to ask them to swallow, don't give them entry coated. Chewable is preferable.
Yes, sir.
Okay. But I think nowadays chewable aspirin doesn't come only. So
Yes.
practically aspect is when you're giving aspirin, which is entry coated, ask them to chew and swallow. That's what you'll have to tell them. Not swallow, not just swallow blindly, chew and then swallow.
Chew
That's
and-
fine.
Yes, sir.
So what is, I think culprit vessel, I think we discussed in detail.
Just
So
culprit.
someone again just messaged what is culprit vessel. I think we discussed. Someone
So-
just
So culprit vessel, what do you mean by that? When there are more vessels involved, you're going to only go and manage the
Major
culprit
vessels.
vessels with
Maximum
angioplasty, right?
Yes,
So,
sir.
and in this particular patient, you said that it is a RCA.
Yes, sir.
Okay.
someone just messaged ECMO. I don't mean to understand what.
Okay.
Very
Probably they're asking you what is the role of ECMO? Is there any VA ECMO? Is there any role of VA ECMO in terms of mortality in the trials that have come back? Can you name some trials that have been looked at?
Dr. Shiv?
ECLS, right?
ECLS shock trial.
ECLS shock trial, sir.
Ah.
It is it show no mortality benefit, sir, initiating the.
So very good. So you're talking about the ECLS shock trial and the ECMO cardiogenic shock trial. No?
Yes,
In
yes.
both, did it show any mortality benefit?
No, sir.
No, sir.
No, sir.
And
Okay.
finally, Dr. Rahul is saying ARDS should not be in the diagnosis as this is a cardiac cause.
Was ARDS in your diagnosis?
It is written
Yeah,
on
yeah. Type 1 respiratory failure, ARDS, pulmonary edema.
I probably agree with Rahul here.
Yes, definitely. Is ARDS written in your diagnosis? Yes.
So we
So
should
if
highlight the main diagnosis. I mean, you don't even on mechanical ventilation is fine, rather than having type 1 respiratory failure, moderate ARDS.
Okay, can you just modify this and say that this is acute cardiogenic shock with hypoxemic respiratory failure needing mechanical ventilatory support, which is what it is, no?
Yes, sir. Yes, sir.
It's not ARDS.
So it was a nice interaction. Thank you, Didipya sir. Thank you, Saurabh sir, for joining for the session. It was really interesting. Any final comments, sir? Didipya sir?
No, I think a very well done case, a difficult case to do it. Manindra, do you want to add something on certain aspects?
I think almost all were covered, sir. Pulmonary artery pulsatility index was one thing which we missed out on.
Okay.
So whenever we are planning about any device, along with the cardiac power output, we usually look at pulmonary arterial pulsatility index also. And PA catheter is again back in. So in cardiogenic shock, the 2026 AHA guidelines also clearly recommend that if your center is capable enough of managing the PA catheter, please go ahead and put a PA catheter as a dictum. And once you put a PA catheter and you look at the pulmonary arterial pulsatility index based on the PAPI, if it is less than 1, that means that there is a definitive RV failure also. So whenever there is a definitive RV failure, we cannot just go for a LV support device like an Impella or an IABP because it can cause more harm. As soon as you are unloading the LV, the RV strain further worsens. So you have to look at the RV also. So generally what we are doing is we are still not using PA catheter so much. We are using TAPC. So we are using TAPC, and based on the TAPC, we are deciding whether we want to support LV or RV. Actually, today only we did the tracheostomy for this patient, sir. So because it was my patient, I was not talking too much, and both of them have handled this case from day one.
Right.
So
It was very well handled, actually.
I think,
A
yeah,
difficult case.
difficult test, well handled.
Fortunately, we are having a lot, we, as per the AHA guidelines, we are having a lot of hub and spoke models, sir. So our hospital is tied up with almost 15 to 20 surrounding hospitals which don't have a PCI capability. So whenever we get a call, our ER team usually takes the call. So in this particular patient also, one of my ER team went there, assessed the patient, and in the transport also we took care of the shifting. We tried to convince for a angiogram when the patient came to the ER, but the patient had a cardiac arrest, patient was in shock. I mean, it was not very easy. And the reason why ARDS has been added is because we did a CT test that was not mentioned because we wanted to discuss more on the cardiogenic shock component. So there was a little bit of aspiration pneumonia also. So that is the reason I think my Sai Kishan has added ARDS. Right lower zone has a little bit of aspiration. I wantedly omitted those part because I wanted the discussion to be purely on cardiogenic shock. So I think,
Yeah,
sir,
please continue.
about the mechanical circulatory support, day one we told about IABP and all, but fortunately within 24 hours, clinical condition improved. Initially, finances in Indian scenario, everything finances also again come back to the picture. So they were not very keen on anything as long as the patient's neurological outcomes were not clear. Once patient became conscious, they were willing to do everything aggressively. So even for the angiogram, we had to push the cardiology team because they were also little not very keen because he just recovered. So we had to push the cardiology team. So literally we pushed everyone. In fact, if the stroke event did not happen, probably today or tomorrow he would have gone for a CABG. But unfortunately, he had a stroke and now it is postponed.
It could be fortunate also. Maybe you would have had a stroke post procedure and then it would have been difficult also. So I think it works out good. I just reiterating the point of Dr. Manindra, we just need to reiterate that point. He just told us how do you manage cardiogenic shock. If this patient is having cardiogenic shock C and beyond, you would need this patient to be on vasopressor therapy. And we did talk about Dr. Saurabh did talk in length about the SOAP trial and how you prefer noradrenaline as first agent over any other drug. And then he did ask them about the question of when will you choose mechanical cardiac support device, and they did tell about cardiac power output. So your cardiac output times map by 451. That tells you if it's less than 0.6, you need a temporary mechanical cardiac support. And then Dr. Mahindra did add another fine point on it. He's saying, yes, you need a mechanical cardiac support. What type of device should you? Should use only a ventricle assist device? You will use a biventricular assist device. That is made on the decision of also looking at the PAPI. So when you talk about the PAPI, that will be PA systolic pressure minus PA diastolic pressure by the by the CVP. And if it is less than 1, then it shows that the patient has severe RV failure as well. So in these patients with a PAPI less than 1, you can't, and he needs a support, you just can't put a left ventricular device alone. You also have to put a right ventricular assist or a biventricular device. So that's a very important point that has been raised. And I think the purpose of doing this webinar is to familiarize people who are not familiar with those devices, devices, and get the concept through. Is that what was the
Absolutely.
idea behind this case?
Absolutely, sir.
Okay. And I think we did discuss about ECMO, how ECMO in this situation may not be useful in the light of the trials. And of course, IABP was discussed by Dr. Saurabh in great detail as well.
So Saurabh sir, you want to add anything?
I can't add much after you two have spoken and covered everything. But it was a difficult case, well managed, and it's a tough case for exam as well, to be honest.
Thank you, sir. So with no more questions, I would love to thank Saurabh sir and Didipya sir for accepting our invite and for being our examiners. So we'll close the session, sir.
Thank you very much, sir. Thank you
Thank
for
you,
the
sir.
opportunity.
Thank you,
Thank you, sir.
Thank you, Manindra.
Thank you.
sir.
Thank you. Thank you.